All right. So next, all right. So next up, I'm going to bring Trudy Matthews up. She's going to tell us about UK Healthcare and the Advancing Kentucky Together initiative. It's a really cool thing we're doing throughout the state that I think you'll find really exciting. And then she's also going to give us a legislative update because we know there's a lot going on out there that she'll tell us about. Just a quickly tell you a little bit about Trudy. She serves as the Chief of Value-Based Programs, Public Policy, and Community Initiatives in the Office of the Executive Vice President for Health Affairs at UK Healthcare. In this role, Trudy works with UK Healthcare's executive team and ambulatory leadership to ensure success in value-based programs and government affairs. And of course, like I mentioned before, Trudy's also our executive director here at the REC. So let's have Trudy come on up. Of course.
I always love to follow Amy because it scares me so much I go home and change all my passwords. So you've accomplished something really good here today, Amy. I just want you to say that. I just want to say that. So today you get a little bit of a twofer. Because you're going to get two presentations in one. We started out with me just giving it a update on a new initiative that UK Healthcare is launching called the Advancing Kentucky Together Network. And then we had several clients say, is somebody going to talk about what's happening in Washington? And we were like, but then we had several people say, can somebody please talk about what's happening in Washington? And so I got voluntold that I was going to do this update. No, I'm just kidding. I had just done this presentation for the statewide physician liaison program. So I get to do it again for this group. And I'm excited to do it because we live in interesting times. We live in interesting times. So let's get started. First of all, I'm going to talk about, let's start with the good side of things. I'm really excited about the new Advancing Kentucky Together work that we're doing at UK Healthcare. Some of your health systems have been a part of UK Healthcare's affiliate programs or have worked with UK on a number of kind of specialty type of relationships and affiliations. And really Advancing Kentucky Together is the next step in the evolution of that model. I'm really pressing the button and it's really not advancing. I'm pressing green. Watch, here we go. Technology. Oh, there we go. Okay, thank you. Jared's helping me out back there. So Advancing Kentucky Together, what is it? So the university exists to advance Kentucky. That is our mission, why we get out of bed. People ask me like, oh, you've worked at the university for a little bit. I worked almost 11 years here in Lexington for the university. And one of the things I love is that it's just a bunch of smart people doing smart things to make the Commonwealth of Kentucky better. Who doesn't love that? I love working at the university. And part of my job is also doing the work to do outreach to all of our partners across the Commonwealth and help hearing from you what your problems are and trying to figure out, are there resources or expertise or some kind of technical assistance we can provide. That's really the impetus of the whole Regional Extension Center. So we're part of the Advancing Kentucky Together network work, the Kentucky Regional Extension Center. And really we're trying to take our education, research, outreach and service missions and continue to do even more to advance Kentucky in all that we do, and specifically in the area of health. And I want to talk about how that is involved. So the priority areas of Advancing Kentucky Together are going to be around healthcare access and innovation. And so the Kentucky Regional Extension Center team and our outreach team at UK Healthcare is a part of this work. We're really excited about some of our new partners. We already have 3 healthcare partners in the Advancing Kentucky Together network. We have Appalachian Regional Healthcare, Pikeville Medical Center, and then the Kentucky Primary Care Association, who are our first members of the ACT network in Kentucky, and we just hope to grow that over time. You can also see that there are some education partners, so there's a lot of work that we're doing with some of our partners in education. So there are those pipelines that we're working on within the healthcare workforce pipeline, there's a lot of work going on around how we can smooth the transitions. Let's say if someone at Center or at Transylvania is getting a degree, an undergraduate degree, how do we make sure that it's a seamless transition for them to go into a graduate degree at UK and that they don't have to go through a lot of rework? So that's part of what is part of these education and opportunity pipelines. And then workforce and economic development, really leveraging a lot of our partnerships in that space. And then I'm going to talk a little bit about community and land grant engagement, because that's a part of our Advancing Kentucky Together network work that I'm the executive sponsor for UK Healthcare, along with Dean Laura Stevenson in the College of Agriculture, Food and Environment. And it's really exciting. So many of you know, or maybe you're part of the Marquee Network, and we're so excited to have some of our affiliate partners here as exhibitors, or the Gill Heart Affiliate Network, or Stroke, or the Kentucky Children's Hospital Network. Really, our Advancing Kentucky Together network is kind of a super affiliation agreement in that we're kind of rolling up a lot of different services we provide as a university, and then having a conversation with our partners around what areas and what problems do you want us to solve. And we're going to have in these 4 areas that I just talked about, kind of off-the-shelf resources that we're developing for our partnerships. And we looked at, you can see already where we have a presence all across Kentucky, and we're looking to expand that even more. So I want to talk about 2 areas that I'm really excited about. So first is like the Advancing Kentucky Together Network healthcare innovation space. And again, this is really around kind of taking some stuff that we already do and just continuing to make it even better. So many of you have worked with us around our quality improvement work. And but what we don't often do, where we do some at the elbow support, but a lot of times our work has been a little bit less, is more episodic, as you have a need on a certain condition. But really what we want to try and do is back up and say, let's figure out how we can help you with the infrastructure around quality improvement. Let's figure out how we can help you with your data, and maybe doing some data validation work. And so some of those services would be offered through the Advancing Kentucky Together network. So that's on the healthcare side. Then I mentioned this partnership that we have, that we're building with the College of Agriculture, Food and Environment. I don't know about you, but I work in a really large organization and there are silos. I know that all of you, nobody in your organizations ever deals with silos, do you? You all are completely seamless communicators wherever you go. No, actually, we all know that there are silos. In fact, I was talking with one county extension agent who said, our local public health department office is right across the parking lot from us, but we don't really ever talk to one another. But yet we're both active in the community working on common things. And so the work that we're doing with the College of Agriculture, Food and Environment, as well as the College of Public Health, is really around these thorny problems in health, the leading causes of death and disability in Kentucky: cancer, heart disease, diabetes, obesity, tobacco use, those things that we know are challenges to the health of Kentuckians. How do we break down our silos and work more seamlessly across our county extension offices, which are in all 120 counties in Kentucky? How do we work with our local public health departments who are also in those same counties? And then a lot of you all who are our health system partners, you're working on these same issues as well. But yet a lot of times we may not be really collaborating around some of these thorny problems. And it's not like the university has all the answers. You all have the answers too. So let's have a conversation about what really some of these big thorny health issues. Part of what got this conversation started was in the 2024 community needs assessment that the College of Agriculture, Food and Environment did, is that several really big health issues emerged as the top challenges that leaders in counties around Kentucky said they were dealing with. Things like substance use addiction and recovery, improved access to mental health and well-being resources. There are a lot of ag and youth-related items on that community health needs list as well, but then also things like food is health and food insecurity. And those aligned very well with UK Healthcare's goals around behavioral health improving chronic disease outcomes, making sure preventive services are available all across Kentucky and helping to support that, as well as working on health disparities. And so that began a conversation. And I want to talk about so we're kicking off some demonstration projects across Kentucky. Our first big community conversation is going to be happening in December with our partners from UK King's Daughters and the Ashland community, because they're working on their community health needs assessment. And so we have, again, it's the university sometimes can be like, well, we're going to show up and we know everything and we're going to tell your communities what to do. That is not what this conversation is intended to be. But the university does have some expertise in the areas of behavioral health, population health and chronic disease improvement, health disparities, and then the healthcare workforce pipeline. And we have some assets that we could offer to help communities. So in a very humble way, co-partnering, co-collaborating with the communities, we want to ask the question is, you care about these issues of depression, anxiety, and the increase in suicidality in our state, the rampant nature of these chronic diseases that are killing and disabling Kentuckians faster here in our state than in other states. Let's work together on some of these thorny issues. So I want to talk about kind of 3 areas that I'm really excited about, but there's so much more that we can do together. So one is in the area of behavioral health. Our Healthy Kentucky team is here today, and they have some resources about this program. But in conversation with our behavioral health leadership team, after the pandemic, we began this conversation of how do we help our communities across Kentucky with the huge spike in the number of people who have mental health issues, and then the just how we see suicidality impacting communities. Our own community here in Lexington, King's Daughters in Ashland, St. Clair, Moorhead, but also all across Kentucky with our partners. And so our behavioral, as we began talking, one of the things they said is like, really, if there's not enough mental health providers in this state, we're working on that, but we're not going to be able to produce those mental health providers as fast as our need is. We really need to equip everyday people to have conversations with their loved ones, their colleagues and coworkers around the issue of whether or not someone is thinking about hurting themselves. And do they have a plan to take their own life? And so our behavioral health leadership team had used the question, persuade, refer training with their own people, and said, really, there's like this QPR gatekeeper training that's available just an hour. The licenses are not very expensive. So we just tested it with UK, and we made it available, this 1 hour, available 24/7 online training with UK healthcare employees and across the University of Kentucky. And we got a fabulous response from people like, thanks for providing this. I really needed this. This is such a useful training to me. I took it myself and I'm like, oh, I have 4 kids and I wish I would have taken it 20 years ago, because I think it would have helped me so much to have a conversation with my own kids, especially like in whose middle schoolers are not depressed or anxious these days. I mean, so I wish I would have had this training so much longer ago. Well, now we have more than 3,800 Kentuckians who've taken the training, and we're working together with communities to continue to expand it even more. And then partnered with 988, we think it could be a really powerful tool to make sure more people are getting the help that they need across Kentucky. So that's just one piece of how we're partnering around behavioral health, but there's so much more that we also have available that I could talk about. But I also want to talk about food is health, and that we're expanding our resources around food insecurity and how and our resources to help individuals who have special dietary needs. If you have kidney disease, man, that's weird. What you can eat, what you can't eat when you have kidney disease is really weird. And trying to figure that out and what you can cook and what you can eat, really hard. Heart disease, cancer. At certain times people have cancer, like there's certain. So really helping people to, if they have certain types of chronic conditions, recalibrate how they're eating and what they can eat, because we know that what you eat is often as helpful in your management of diabetes, heart disease, and other conditions as the medicine that you're taking. So that's another area that we're working at again. And also another part that is part of this as well is our healthcare workforce pipeline. We've done a pretty good job, I think, around nursing and physicians, but we all know like how many people need rad techs, surge techs, other types of really hard to hire positions, diabetes educators. I could go on about what the really tough things are to train and to get access to. And so we're trying to expand our pipelines for some of those harder to train and then also just getting more people interested in healthcare professions as well. So I'm going to if you're interested in learning more about that or being a partner with us, thinking about advancing Kentucky together, talk to me because I would really love to hear about what you feel like the needs are in your community and if any of these things that we're working on building resources around is of interest to you. Okay, I'm going to pivot now to part 2 of my presentation, which I'm going to talk about the legislative update. Now, I have worked in and around politics, oh gosh, it's going to age me, for more than 30 years. But there is a tremendous, I have never seen the level of change in healthcare that I've seen in the last year. It has been tremendous. And if you're not a person who likes politics or has to do it for your work like I do, you're probably scratching your head a little bit and trying to figure out what is it, I'm going to click through my Advancing Kentucky, what is it that I should prepare for? There's so much change. What things are really the most impactful things? And why the heck is our government shut down and when is it going to end? I'm going to try and answer all those important questions today. So hold on to your hats. Here we go. How much time do I have, Megan? What time am I in? Okay. All right. Well, just somebody wave a thing at me. Oh, Jared's going to be giving me hand signals like, cut it off. Stop talking now. Okay. May you live in interesting times. In healthcare, I've seen so much change over the course of the 30 years that I've worked in healthcare, 30 plus years, unfortunately. I'm so old, I feel like some days. And we're always working on these things of like healthcare accessibility, healthcare quality, the efficiency of healthcare. And the thing about it is that usually when you're working on one, you're generally going to impact the other. And you only ever, on your best days, feel like you get 2 out of 3, right? By working on one, you're going to cause one of the other ones to go out of sync. And that's the way it feels like right now to some degree. I will also say, as I'm beginning to talk about some of the changes that have happened in healthcare through the Budget Reconciliation Act and continuing conversations, I'm part of the university and we try to be, and especially in our government relations work, we enforce a lot institutional neutrality, which for us means we don't take a partisan side. We try to bring facts and science to bear to the issues of the day. I am myself very much, I can see all parts of the political spectrum. I've been at this long enough. So I'm not going to say there's bad guys and there's good guys in this conversation. There's just you and me, and sometimes we don't agree, right? As I say. So I want to just put that caveat there. But there are a lot of changes that are going to affect healthcare. So I'm going to try and stick to the facts of what is going to be affecting healthcare going forward. And mostly I'm going to focus on Medicaid. Now, there's one important thing that I think in the Medicaid conversation, like especially in the popular press, that gets completely missed out on, is that most of the Medicaid provisions in the in HR 1, the One Big Beautiful Bill Act, is that they affect the Medicaid expansion population. Medicaid, so I think Medicaid expansion on all these things we're talking about. Some people don't know that there are actually 3 different populations within Medicaid. There's the traditional Medicaid population, which are those categorically eligible populations of individuals who are, pregnant, children under the certain poverty level, individuals who are disabled, the elderly who are frail and who are poor. Those individuals are categorically eligible. Those are generally going to be covered, not children so much, but through the traditional Medicaid population. Then you have your CHIP population, your children who are covered through the Children's Health Insurance Program. And then you have Medicaid expansion. And that's the population that was brought in through the Affordable Care Act. So for instance, like 20 years ago, if you were a single man, no matter how poor you were, you could never qualify for Medicaid because you didn't fall in those categorically eligible populations. Well, now a single man who is under the poverty level can be eligible for Medicaid. And under the Medicaid expansion work. So kind of bear that in mind as we talk about some of these changes, that it's really going to focus mostly on the Medicaid expansion population, that last category that we talked about. So there are kind of three provisions I want to talk about really quickly, just around eligibility. So there will be work requirements for able-bodied individuals covered by Medicaid expansion. They'll be required to engage in community service, work, or other activities in order to keep their Medicaid coverage. This does not apply to individuals who are in the traditional Medicaid population, like individuals who have disabilities are going to be exempted from this requirement. There also will be eligibility redeterminations. So we're moving to, you may know that during COVID, eligibility redeterminations were basically put on hold. Well, now we'll have those happening every 6 months. And just because people have to, in essence, kind of reapply or verify that they're eligible for the program again, some people are going to fall off. So there's going to be a little bit more churn to our Medicaid population. And then there will be increases in cost sharing for the Medicaid population. They've kind of increased what those targets are. And then there are limits to retroactive coverage. So those of you who are in hospitals, this is actually kind of a big deal because there are people who will show up in our hospitals who are actually eligible for Medicaid, but they're not enrolled yet. So retroactive coverage will not go back 60 days like we've been used to. It'll only go back 30 days. So there will be some people who may have seen, their physician, 45 to 60 days ago, and then they come into our hospital. Generally, you can do that retroactive coverage, so that first physician visit would be covered. But now some people may have to pay those pockets pay the out-of-pocket costs for if they're then found to be eligible for Medicaid. So again, 30 days prior, all of these things together mean that there are going to be individuals who will be losing coverage. Probably, and there's some estimates I'll show you of what that will look like. So for those of us as health systems, we need to prepare for that. The next thing I want to talk about is state-directed payments. So there are a couple of provisions that are important there. Basically, directed payments are going to be capped going forward at 100% of the Medicare rate, but we don't really know which Medicare rate are they going to pick? And is it going to be Kentucky's Medicare rate we're going to be capped at? Because we have a really low Medicare rate. I want New York's or Alaska's. Thank you very much. But more of that will be coming out in rulemaking. That affects all of the hospitals in Kentucky because every hospital participates in either one of two programs. The Hospital Rate Improvement Program, which is for the community hospitals, and the Kentucky Hospital Association coordinates that program, or the University Directed Payment Program. And then there's also another program called K-THRI, which is for high Medicaid volume participants. So your hospital or health system, if you're here today from one of those entities, is probably going to be affected by this. There is a grandfathering provision in this cap, though. So this is really important for Kentucky in that we will get grandfathered in at our current rates, again, open for interpretation what current means, for the next 2 years. And then we will have to reduce our payments by 10 percentage points. Percentage points is a very important distinction. Not percent, 10%, those are different, until we get our rates to 100% of Medicare. What I will say, the bad news in that for all of us is that Kentucky's directed payment programs are much higher. The supplemental payments are much higher than Medicare. So we're all going to feel that probably over the next few years. So those are kind of the big provisions that have big impacts. There's so much more that I could go through. I have a timeline that's 4 pages of the various provisions. There's a lot of stuff about the ACA exchanges that are going to be changing as well. That too will impact coverage, but I wanted this to be a fairly reasonably lengthy conversation. Another thing just to be aware of is that there are also policy changes to the Graduate Plus Loan Program. So this is going to impact our pipeline of physicians and people who are going to be able to go to get a medical degree. So that that program is capped now at 200,000 total, 50,000 annually. And the Association of American Medical Colleges estimates, it basically says nearly 40% of medical students rely on this loan program to finance their medical education. So we're worried that there are going to be some people who are going to be making different decisions about whether or not they become doctors or not. So again, this really, I think, could exacerbate our physician shortage pretty substantially. Now, one of the good news in the One Big Beautiful Bill, HR 1, was that there is a pretty significant amount of funding for rural health transformation. So they set aside $50 billion to be distributed over 5 years to help offset some of the impact for rural hospitals and rural providers. This is in essence about 1/3 of the estimated loss of federal Medicaid funding in those rural areas. The fund will be divided into 2 parts, one that all states get in essence equally, you just have to apply for it. And then there'll be another half, that $25 billion, that's going to be scored based on how great your application is. And CMS issued guidance. It's a little bit of a weird funding opportunity. Matt Coleman is over there shaking his head because they really put some interesting things in there, like if you change your scope of practice rules around for physician assistants, we will score you higher. If you know, just as an example, well, Kentucky has a very restrictive PA scope of practice, for instance. So we're kind of like, all right, okay, how do you score on this one? There are some interesting provisions, but the only entity that's able to apply on behalf of Kentucky is the Cabinet for Health and Family Services. They are actively working on an application for these funds, trying to score as high as they can. But it is a scrambled process because it's due in November, early November, and then the funds will be awarded in late December. And once they score you and give you the funds, you're in for the 5 years unless you just don't perform. So yeah, so hopefully Kentucky will do really well and we'll get a lot of money. That's what we're hoping for. One of the reasons why all of these things really matter is because in Kentucky, Medicaid covers Medicare and Medicaid covers more than half of the population, and we're a state of 4.1+ million people. Covers 1.4 million people in Kentucky. Now, we were talking with some folks from Alabama. They didn't do Medicaid expansion in their state. They're really worried about all the changes to the ACA exchanges because the people who are not, they're not eligible for Medicaid expansion. They've gone on the exchange. So like the folks at the University of Alabama Medical Center are expecting almost the same level of loss of coverage in Alabama, but they're not an expansion state because of the ACA changes. So, I guess the takeaway from that is there's pain to go around whether you're an expansion or non-expansion state. The Kaiser Family Foundation estimates that our uninsured rate could go up by as much as 4%, increasing the number of uninsured by 140 to 230,000 people. So that just means that more practices and more health systems and hospitals are going to be dealing with bad debt for people who can't afford to pay their medical bills here in Kentucky. And you can see that Kentucky's dark blue, that this is going to impact us pretty significantly. Before I go on, let me also kind of back up a little bit and just say there are kind of 2 mindsets about all these changes. And again, I'm not making any partisan, I'm just kind of representing what's out there. There are some people who are like, the sky is falling, the world is going to end, all of these changes are going to end healthcare as we know it. They're usually a consultant who's trying to sell you something. And then there are other people who are like, it's not going to be so bad. We'll figure this out. It used to be that people were not covered by Medicaid. It'll be okay. I have to say, I think there's room for both a little bit of anxiety and a little bit of hope, and kind of like, it might not be so bad. Let me tell you why I feel like it might not be so bad. And it's because I'm cynical about our government process. So please that's my bias. I'm going to be very transparent about my bias. A budget reconciliation bill is, in essence, a way that the government says, we're going to make a big change. And the reason why a lot of policy changes are wrapped up in a budget reconciliation bill is because they only need a simple majority. And look how hard it was to pass that bill with a simple majority. I mean, it was really hard. They wrap up a whole bunch of policy changes in these budget reconciliation bills because you only need 51% of the votes in order to pass it. What happens though, when Congress does that, is generally then they have to take what they put in the budget reconciliation bill and they have to activate it in their regular budget bills. So what happens, and I'll just kind of give an example. In the Affordable Care Act, one of the ways that they were supposed to pay for the Affordable Care Act was by eliminating the disproportionate share hospital program. Guess what? We're 15 years after the passage of the Affordable Care Act. The disproportionate share hospital program is going strong. It was never eliminated, right? But it was slated to be eliminated in the budget reconciliation bill that helped authorize the Affordable Care Act. So what was going on there? It's just basically that Congress, when it comes down to it, oops, excuse me, I'm going to drop, I didn't mean to throw this at anybody. I'm just, I'm not trying to be violent here. It's just that when Congress comes down to it, is it's really hard for elected officials to cut anything, whether Republicans or Democrats, because it's going to cause people pain, and pain means I might not get elected. I think what we'll see is that there was a lot of stuff in this bill that when it comes down to it, 10 years from now, I hope we're all drinking and sipping coffee and we're like, it turned out not to be so bad just because our government never really got its act together to actually make it so in an actual budget. Look at our current process right now. That's a great segue to talking about what the heck is going on with this government shutdown. Part of it is that problem. Thank you, Jared. He's giving me the signal. I got 6 minutes. I have 15.
Yeah.
Oh, that's like, so much sale. Okay, good. That was 115, not 6. I'm adding them. Right. So anyway. Okay, I'm good. Okay. Okay. So I talked about budget reconciliation bill. That only needs a simple majority. That was the one big beautiful bill passed. To actually fund the government, though, you have to pass the Senate, which needs 60 votes. Can anybody tell me how many Republicans there are in Congress or in the Senate? Right? So they don't have 60 votes, right? So the Democrats can filibuster any bill, funding bill in the Senate. So you got to get 60 votes. So the Republicans have to get a few Democrats who will cross party lines and vote for either what they call a continuing resolution, which basically says we can't decide on an actual budget bill. And actually, there are 12 budget bills that have to be passed every year. We can't decide on an actual budget bill. So we're going to just pass a continuing resolution to keep the government funded the same going forward. So basically, that would fund the government. If they pass a continuing resolution, that's basically funding the government at the levels that were the Biden administration funded it. So that's kind of good news for us if they can finally get together to pass something, right? At least in terms of funding cuts. I'm not saying, again, not making any partisan, but in terms of healthcare cuts, we would be funded at a more generous level. So that is kind of the problem that we have. Our government shutdown is basically, it's a big game of chicken between Democrats and Republicans over whose priorities are going to win out. Continuing resolution just funds the government for a little bit longer. I'm not hopeful. I think the longest government shutdown was in 2018. It was more than 30 days. I think, unfortunately, we're probably in for another pretty long shutdown. I really hope I'm wrong about that. That's one of the things I really hope I'm wrong about. But I think it's going to, right now, I mean, even the House they're just not showing up to do anything right now because they're kind of playing a big game of chicken. So all of that is just to provide a little bit of background around the budget process. A continuing resolution would fund the government at current levels, the last kind of level that was approved, and then they're going to have to get back to Washington and figure out what their regular budget would look like. And I don't know. I'm just thinking for the next year or so, we might just have continuing resolutions to keep the government open and not really have any budget bills passed, given the partisan divisions in Washington. So that's not good news, or necessarily, because we really would prefer to have a functional bipartisan world that we're working in. Like, I look back on the times when there was like Newt Gingrich and Bill Clinton worked together on welfare reform. Even, as recently as the Affordable Care Act, there was some bipartisanship. I'm not saying that, all those things were great things or were terrible things. I'm just saying right now in Washington, it's just really hard to get anything done. So that's where we're at in terms of our government shutdown. One thing to bear in mind is that there also are two categories of government spending. There's mandatory and discretionary. So the mandatory things like Social Security payments, those just keep going. Medicare also is a mandatory program. It keeps going, but there are caveats. So like the telehealth provisions and the hospital at home program, they're funded through the regular budget, not through as a mandatory, but as a discretionary item. So those have been impacted. And then there's the issue of contractors, that contractors actually have to get paid to process claims. So it's, most of them have some money in the bank and they can continue to do some of that work, but eventually they're going to run out of money. And then we all won't get paid for the work that we're doing. I think the real probably political pull is around these mandatory workers who have to show up, air traffic controllers, the military, for Pete's sake, who are not getting paid right now. So that's what's really putting pressure on both parties to come back to Washington and to work something out, at least to get a continuing resolution done so that we can have the government reopen. So I just think it's going to take a little while for them to feel the pain and come back. So there's my Trudy armchair analysis of the current government shutdown. Okay, so let's talk a little bit about a couple other things that are happening that are also going to be, that are out there. The Trump administration announced a big, huge, it's bigger than almost anything that's happened in 30 or 40 years within HHS, reorganization of the Department of Health and Human Services. They created a department called the Administration for a Healthy America, and then kind of reorganized and put things in different buckets. So the Administration for a Healthy America took parts of the CDC, that all of their chronic disease programs moved over to this department. The Assistant Secretary for Health, HRSA, which has a lot of the workforce and federally qualified health center and community health center funding, moved over to this program, SAMHSA. Now, the caveat with this is that actually none of this it's on paper currently, but unless Congress comes back and passes it into law through a budget or through some other mechanism, it won't actually happen. So it's these interesting dynamics that we're learning about in our constitutional order. So this is on paper currently to reorganize this, but you might notice that none of the website has changed because they can't really do anything fully about this until Congress authorizes the change and gives them the money in these particular buckets. But the plan is, again, to create this new super Administration for Healthy America agency. And then there are also some kind of interesting things related to what Amy talked about previously. A lot of the compliance functions are going to be rolled up into some new offices. So the Assistant Secretary for Enforcement, there were little pockets of compliance people all across the Department for Health and Human Services. They've now centralized all those people into this new enforcement office. And then the Agency for Healthcare Research and Quality and the Assistant Secretary for Planning and Evaluation, those two things are going to be gone with a new Office of Strategy created to replace them. And then there are lots of other little changes throughout the agencies that are planned. As you all have seen the reductions in force that have happened in the agencies, and really a significant reduction in the scope of the Centers for Disease Control as well that continues. So those are just some things I think that we ought to keep our eyes on. Again, they don't really go into complete effect until there's a budget bill passed. But, for instance, if you're a federally qualified health center, anybody here, you may be moving, right? Your funding may be moving to a new agency, and, there's tons of disruptions because of the government shutdown. And, who knows what's going to happen with all of that, right? Are you feeling a little bit of anxiety? Yeah, I know. It's just, change is just hard because you're like, where's the people who are going to be paying my bills? Where are they now? Right now. So, okay, well, I've got a little bit of time, I think, for some questions. I'd love to hear from you all what you're thinking. And I might not know the answer, but we'll go back and we'll research it if we don't know the answer. Any questions? And again, you can use Menti to submit questions if you don't want to use the mic. I love microphones, so I never understand why people don't want to speak on microphones. Any questions? Don't be shy. Commentary also. Okay. We're looking for whether there's anything coming up on Minty. Should have prepared a joke. Okay, we got somebody over here. Thank you for being the brave first person. Look at that. Yes. Thank you. And speaking into a microphone too. That's awesome. That's for our people who are actually listening to this on Zoom. So we're not trying to make you feel self-conscious. We want to just make sure people hear the questions.
Sure. I just want to say thank you for laying out, as you did, the One Big Beautiful Bill impact areas. I don't think I'd been able to see that laid out as well as you have put. When you're watching the news and you're combing through the internet, there's so many different.
What should I be thinking about?
Exactly.
Yeah.
So I was able to write some things down to really.
And these slides will be available to you all as well.
Really
So, yeah,
appreciate
yeah.
that. That really helps identify, kind of really lay it out. So thank you so much.
You're welcome. You're welcome. Thank you. I appreciate that comment. Well, that was very sweet. Thank you for doing that. One thing too, also to related to that is, I didn't mention this before, but your comment made me think about it. Some of the things in the bill don't go into effect for a little bit. So the work requirements, you can see it's 1/1/27, 1/1/27, 10/1/28. So just keeping track of when things are going to go into effect is a little bit of its own game of, soccer for all of us who are working on this. So do pay attention to the effective dates because again, unless Congress puts it in some kind of budget bill, it might not come to be. Do you anticipate the telehealth waiver being extended or potentially made permanent? I would have expected it to be made permanent. I think it's a budget issue in that they've got to, if they put something in the budget, they've got to find some way to finance it. It's got to be budget neutral generally. And so I do think that they will extend the telehealth waiver, especially for psychiatric telehealth. I think that there's just so much groundswell of support for that. But again, paying for it has been the little bit of the challenge. And then I think the potentially permanent, the reason why they keep doing it through kind of continuing resolutions or budget is just telehealth is an expense. So I'm not sure that they're going to make it permanent, but they will probably continue to put it in there because people really like it. So that's, I could be wrong, but I think that's probably a likely scenario. If I were betting in Vegas, I'd bet for that the telehealth waiver would get into, we'll get into a continuing resolution. Good question. Okay. All right, well, we are about at time. We can move along. We can be 5 minutes early, can't we? We sure can, because everybody likes ending early, right? I will want to put in, for those of you late today, we added Tamate to talk about AI. He's phenomenal. If you're thinking about leaving early, don't, because he's really great. You think I'm a fast talker? He's really a fast talker, but he's also phenomenal. So I'm just going to put a plug in there. All your AI questions will be answered by Tamate because he's amazing. So with that, I'm going to pass it back over to Megan. Thank you all very much. I also have, if you are just curious, this great timeline of when everything goes into effect. I keep this as like this handy little reference so I know because it's really complicated to keep all of this straight. All right. Thank you, Megan. Thank you all.